Good afternoon, ladies and gentlemen. The thyroid gland was first described in the ancient Egypt, but its function was not fully understood until the 19th century, and yet there are several things we need to know about this little endocrine organ. During my PhD work, I would like to examine the blank spaces of differentiated thyroid cancer patients. My name is Máté Orgoványi. I'm a third-year internal medicine resident here at the Uzsoki Hospital, Budapest. And with my only and precious team, we wish a better management for these patients due to the mission to provide evidence-based knowledge, which would be investigating the predicting accuracy of different risk factors of papillary thyroid microcarcinoma and investigating the radioactive iodine treatment as a risk factor for second primary malignancies in differentiated thyroid cancer patients. My first project will be done by the methodology of systematic review and meta-analysis. The number of the papillary thyroid cancer are rising, however, the mortality remains stable. The reason behind this phenomenon is the better ultrasound images, because we can detect tumor under the size of 1 centimeter, which the literature calls microcarcinoma. As you can see the death rates, which is the blue line, the active surveillance came to fore firstly in Japan as an alternative treatment, because this disease is a very indolent one. Instead of the immediate surgical procedure, with this approach, we can avoid over-treatment with the possible side effects. Unfortunately, there's a certain percentage that the tumor will progress, which means tumor size enlargement or appearance of novel lymph node metastasis or extrathyroid manifestation. The risk factors of progression currently is unknown, so our aim to investigate these factors associated with worse prognosis in PTMC. From a clinical approach, I would like to demonstrate a case of a 65-year-old female singer where we performed ultrasonography and we detected a nodule with a suspicion of malignancy. We performed a fine needle aspiration cytology, and the results turned out that is a papillary thyroid microcarcinoma. As reported by the guidelines, the active surveillance would be an excellent treatment option, but if we know the risk factors of the progression, maybe we can prevent it on time with personalized interventions. Based on this, our clinical question would be which factors elevate the risk of progression in papillary thyroid microcarcinoma. We would like to use the PFO framework, which means the P is the population, patient with PTMC, the F is the factors, which we separated into 2 subgroups, modifiable and non-modifiable factors, and the O is the outcome, which is the increase in tumor size or lymph node metastasis or extrathyroid manifestation. Our hypothesis would be that certain biomarkers are associated with the progression of PTMC, with the clinical implication to avoid undertreatment. I have collected all the key articles, and here you can see one example about it, as risk factor is the age. Luckily, most of the studies are prospective, multicentric ones. We can assess more variables with high-quality data. Unfortunately, there's a limitation which would be the nationality of the population. For our search protocol, we use the search key, consists of 1 domain which describes the population. The systematic search was conducted in 3 databases, and here you can see the number of the results. Altogether, we found 2,000 articles, and I have already done the duplication removal, and with my help of my co-investigator, we did the abstract and the title selection also, and we are doing the full text selection. In this slide, you can see my progress charts. My second project focuses on the carcinogenic effect of radioactive iodine treatment as a risk factor for second primary malignancies in differentiated thyroid cancer patients. The differentiated thyroid cancer is the 9th most common cancer worldwide. Luckily, we have good and excellent management, which would be the radioactive iodine therapy. The radioactive iodine is a radioisotope with the emission of beta radiation, and it has a carcinogenic effect. During the treatment, the thyroid cells, including the cancerous one, uptake the radioiodine with the help of the sodium iodine cotransporter, and it will cause the DNA damage. Unfortunately, there are several organ systems which can also uptake this radioisotope, and it will cause second primary cancer, which is independent from the original thyroid one. Despite the fact that this treatment can cause tumorigenesis, this therapy improves the overall and disease-free survival in these patients. So our aim to examine the occurrence of second primary tumors after radioiodine treatment. Our clinical question would be, does radioactive iodine treatments elevate the risk for developing second primary malignancies in DTC patients? We would like to use the COCOPOP and the PICO framework. The context and condition would be second primary malignancy, surgical treatment with the radioisotope treatment, and the population would be the DTC patients. And in the case of PICO, the population would be the same, the intervention would be the same, and the comparator would be just the surgical treatment patients. And the outcome will be the SPM. Our hypothesis is that radioiodine treatment increased the occurrence of primary malignancy with the clinical implication of closer follow-up. I have gathered all the key articles, and I have done a preliminary search with our preliminary search key, and here you can see the number of the hits. Summarizing what was heard, if we manage to prove our hypothesis, we will make a better decision during our everyday practice. Finally, I would like to close my presentation with the words of Zora Hurston: research is formalized curiosity, it is poking and prying with a purpose. Thank you for your attention.
Congrats on your presentation, Máté. It was a really nice progress. My question is that I've read that this radioactive iodine can enter the lacrimal gland and the salivary gland. Does it cause any secondary malignancy process there, or some side effects?
Thank you. The literature doesn't mention this kind of tumorigenesis in the salivary glands, but it can cause secondary dry eye syndrome.
Hi, thank you. First of all, great presentation. My question would be if there are any specific patient subgroups which are most susceptible to radioactive iodine treatment.
Radioiodine treatment subgroups?
Yeah.
No, it's an everyday practice. We use this for these patients, more likely for the malignant, not for the high-risk patient, not the low-risk patients. I can describe what is high risk and low risk, but I think it will be long.
Very nice presentation. I have one question. You mentioned that ethnicity could be a limitation. Why is it?
Yes, that's a good question, because the thyroid glands depends on mostly the iodine supplementation, and we know that these studies mostly from the Asian countries, and Asian people, it's well supplemented with iodine because of the seafoods.
Congrats on your presentation. What kind of tumors can occur after radioiodine treatment?
Mostly hematologic. Acute myeloid leukemia or acute lymphoid leukemia.
Congratulations for your presentation. I wanted to ask you, in your first project, the papillary microcarcinomas were confirmed by fine needle aspiration biopsy, all of them?
Yes, all of them.
Thank you.
Congratulations on this presentation. You see meta-analysis these two projects?
It was from 2022. It was a Chinese meta-analysis. Mostly they examined the same risk factors, except the genetics, the BMI. They didn't find any good results. So in the current situation, we don't know the risk factors for the progression.
Thank you very much.
I would have one. Could we have a look at the search key of the first project?
What? Sorry.
Could we have a look at the search key of the first project? Because I didn't have. Okay. Don't you think it is too narrow to include low risk?
Yes, it could be, but most of the literature and the guidelines use the low-risk terminology, and the active surveillance is just in the case of low-risk papillary thyroid carcinoma, which is depend on we are in America or in the European countries, because they use different stadium. The American one use theirs, and in Europe and in Hungary we use the TNM classifications. So yes, it could be a problem. We know that, but
without this key part, what would be the number, the total hits of articles? Would it be too high?
No, in my case, it won't be too high.
Okay.
We decided to use this because in America they use this terminology, okay. And in the case of this topic, they didn't do any. They do studies, but not a lot of one. But the Japan, South Korea, and Chinese studies use the same terminology.